This patient has ophthalmoplegia with enlarged extraocular muscles, but no clinical or biochemical evidence to support a diagnosis of thyroid eye disease. The eye is prepared using aseptic technique, with the lashes retracted as per squint surgery to avoid inadvertent foreign body retention within the subconjunctival or subtenon space. Post-operative granulomas secondary to lash retention have previously been described. A silk traction suture is placed at the limbus, and a peritomy is made to allow access to the superior and inferior borders of the medial rectus. Motor fibers enter the muscle between the middle and posterior 1/3 and are generally found on the innermost layer of the muscle. Therefore, these should be avoided using an anterior approach. The muscle is isolated and exposed as per any standard squint operation. Cautious diathermy is applied, though this generally should be avoided onto the muscle itself, as this may cause histopathological artifact. Once optimal muscle exposure has been achieved, a biopsy can be taken in the plane parallel to the fibers, as this may confer reduced risk of restrictive strabismus and muscle rupture, as well as providing longitudinal fibers for histopathological assessment. Minimal handling of the biopsy is probably advisable to reduce crush artifact and improve histopathological interpretation. In this case, a further biopsy is taken from the superior border of the medial rectus in order to improve histopathological yield. The conjunctiva is then closed using buried atovicral sutures. Significant complications of extraocular muscle biopsy are not well described, though these may include strabismus and rarely rupture of the muscle itself. Enlarged extraocular muscles can occur in a wide spectrum of disease, which can include inflammatory eye conditions such as thyroid eye disease, IgG4-related disease, as well as myositis and granulomatosis with polyangiitis. Primary and metastatic neoplastic processes, particularly lymphoma, are also well described. Though infective, vascular, as well as depositional processes such as amyloid can also cause extraocular muscle enlargement. Ultimately, however, the constellation of clinical, biochemical and radiological findings, along with the pattern of extraocular muscle involvement, will ultimately lead to the diagnosis. Where these features do not give weight to a diagnosis, biopsy of an extraocular muscle may be indicated.